Hi everyone. So the long awaited, the most expected NEET-PG exam is over. Hope you had a good exam and you did much more better than expected and extremely making you happy. Okay? So I hope everyone is happy and have done well in the NEET-PG exam. And always the exams are like expect the unexpected. And this NEET was half and half, like 50% of expectations were fulfilled and 50% of expectations were not fulfilled, or the expectations were not uh, uh, were up to not up to the mark. Okay, the way what I want to say is, we expected, like, we had number of questions reduced, the duration being maintained. We thought the scenarios will be very very big. Okay, but the thing this time, it was clinical scenarios which were simple, and if you are able to recollect or recall whatever you have learned, would have been able to crack the exam. That kind of exam was this NEET-PG as scared from people. And today I'm planning to discuss the NEET-PG pattern topics. Okay, it's not the exact questions we are going to discuss. We are going to discuss whatever pattern of questions being told around. Okay, and these are the high yield topics which can be helpful in your further initiate exams and in your uh, uh, forthcoming NEET exams for the juniors who are now in internship and who are in final years. Okay, so it will be really helpful for them, and for you people, just a recollection of things. Okay, it's going to be a recollection of things. And as I told, expect the unexpected. This time I was expecting much more topics, much more questions from COVID, but to our surprise, the questions were very limited in COVID. Okay, or it was very not even a single question being asked in NEET regarding this COVID pattern of questions. So it was little to say it is little unlucky to not have any questions with regards to COVID. Okay, so we had a bunch of questions from different topics, and all these questions were clinically correlated questions. So it was like first year correlated with the final year, second year with final year, so that kind of questions. Okay, so from the NEET pattern, what I hear, we are going to recall few questions now. Okay, the similar pattern of questions. The first question I'm going to discuss here is going to be 60-year-old patient presents with shortness of breath. Okay, shortness of breath. Yes, the first point here is shortness of breath and wheezing on auscultation. So this patient is coming like this, and the absolute eosinophil count was around 5,000. Okay, it was elevated, and the chest X-ray showed miliary pattern like this. Okay, the X-ray showed miliary pattern like this. Okay, miliary pattern like this. So what is the diagnosis? Okay, what is the diagnosis? So we have four options here. The first one, I'm going to go from the bottom up. The first one is miliary TB. Okay, why the answer is not miliary TB? Okay, so why it is not miliary TB is, miliary TB usually will have, as said, miliary pattern. Okay, but here the problem is, here the problem is, in tuberculosis there is no role of eosinophil. Eosinophil has no role. So since eosinophils has no role, okay, this is ruled out here. Okay. Then next is hypersensitive pneumonitis. This is also not the answer. Why this is not answer? So when we discussed in our regular class, I told you that hypersensitive pneumonitis, the IgE will be normal, and there will be no peripheral eosinophilia. If you correctly remember from our class discussion, you will know that there will be no peripheral eosinophilia. The IgE level will be normal. Okay, so this is again ruled out. And bronchial asthma. Bronchial asthma, definitely you are going to have a shortness of breath, wheezing of auscultation, and the eosinophil count can be increased. That is for sure. But the patient will not have an X-ray which shows this biliary pattern. Again, this option is ruled out. So the only option we are left behind is tropical pulmonary eosinophilia. Okay, so tropical pulmonary eosinophilia. If you are able to correctly recollect from our class, we discussed about the criteria, right? Criteria, and we also discussed about something called SAFS. Okay, so if you know the criteria of tropical pulmonary eosinophilia, okay, so this patient is from an area where there is an endemicity for filariasis. Okay, and if you see the peripheral blood, the eosinophil count will be more than 3,000. More than 3,000. The peripheral blood film shows the eosinophilia count of more than 3,000, and the IgE level is more than 1,000. More than 1,000. Okay, and if you check for the antibody titers for filaria, it will be increased, and there will be no detectable microfilaria in peripheral blood, and there will be a good clinical response to DEC. So what we fondly call it as ADrPlexus tablet. So this criteria is fulfilled, and this patient can be labeled as having tropical pulmonary eosinophilia. Okay, so here the thing which confuses us is going to be this miliary pattern of X-ray. This miliary pattern of X-ray. So whenever in your exam they have a miliary pattern of imaging, then what you are going to think? You are going to have three differential diagnoses. The first differential diagnosis is going to be the infectious cause. The second differential diagnosis is going to be malignancy, and the third one is going to be miscellaneous causes. Miscellaneous causes. Now, if it is going to be an infection, then you suspect tuberculosis. Suspect tuberculosis. The first suspicion is going to be tuberculosis. The second suspicion is going to be fungal diseases. Fungal diseases. Okay. Then, if the patient is going to be having malignancy, then it is going to be metastasis. So here also there is no role of IgE, and here also there is no role of IgE. So we are left behind with the miscellaneous causes. In miscellaneous causes, we have lot of causes here, but we are left behind with the pulmonary eosinophilic syndrome. Why we are tropical pulmonary eosinophilia or pulmonary eosinophilic syndrome is the answer here is because the key clincher here is going to be the IgE level. As we saw in the criteria, the IgE level is raised. So this question is a similar pattern of question which we discussed in our class, and the answer is going to be pulmonary eosinophilic syndrome. So we had a separate topic called pulmonary eosinophilic syndrome, if you remember correctly. Okay, and what is the treatment? I also told you the treatment in our regular class. The answer is going to be diethyl carbamazine. Okay, at a dose of 2 milligram per kg, 3 times a day, we give for around 21 days. So this you have to remember. This you have to remember. So this is about the first question, which says that there is a miliary pattern with raised IgE, and our answer is going to be tropical pulmonary eosinophilia. Okay, tropical pulmonary eosinophilia. So the second question I want to discuss here. A 45-year-old male patient presents with progressive breathlessness and fatigue. The clinician on auscultation had a mid-diastolic murmur with a prominent A wave in JVP. In JVP, there is a prominent A wave. The condition is, okay, and usually I want questions like this, which shows video or a picture like this. Usually I wanted questions to be like this, but they just gave the clinical scenario, and imagine this is a patient coming to you. Okay, and if this is a patient coming to you, if you see here, the JVP is elevated. If you see the JVP within the two heads of the sternocleidomastoid, you can see the JVP is elevated, and this is an A wave, okay, which peaks here. Okay, if you closely observe the picture, you'll be able to understand. Okay, so what is your diagnosis? What is your diagnosis? So a patient is coming like this. Okay, so the first point which is going to help us in reaching the diagnosis is going to be a patient has breathlessness and fatigue. So it is either a cardiovascular problem or a respiratory system problem. Two options. Now, next you do a auscultation. auscultation, you get a MDM murmur. MDM murmur means we are dealing with cardiovascular system. Yes, MDM. So what are the conditions where you can get MDM murmur? MDM murmur will be seen in three conditions. Okay. The first condition is mitral stenosis. The second one is tricuspid stenosis. The third one is going to be Austin Flint murmur. Okay, Austin Flint murmur in apex. Austin Flint murmur in apex. So we are left with three options here. Okay, MS, PS, and AF in apex. Okay, Austin Flint murmur in apex. Okay. Now, if you consider these as an option, right? Now in our question we have mitral stenosis, tricuspid stenosis. It's a age-old teaching or classical teaching is whenever you hear the word mid diastolic murmur, our mind will think about, yes, as you said correctly, it is mitral stenosis. You will think, but here it is not mitral stenosis; it is tricuspid stenosis. Why? I will discuss. Okay, I will discuss. Now imagine this as the heart of a patient. So now this is the intraventricular septum. This is atrium ventricle system. Now, the patient develops mitral stenosis. Mitral stenosis. If there is a mitral stenosis, there will be a back pressure which involves the left atrium, and from here the pulmonary vasculature will be involved. Then the pulmonary artery will be involved here. Then the tricuspid valve will be involved, and there will be regurgitation, and regurgitation might cause a elevated AV. Okay, but this is very late manifestation of mitral stenosis, so you cannot expect this to happen here. Okay, but here that they have given a very simple option here. It's very easy to recognize. Is going to be our tricuspid stenosis. Tricuspid stenosis. The tricuspid wall goes for stenosis. What is going to happen here? This R is going to pump blood down. The heart is going to pump blood down. Since there is an obstruction here, what is going to happen? There is going to be minimal flow through the tricuspid wall, and there is going to be regurgitation of blood into the jugular vessels. When it regurgitates into the jugular vessels, what is going to cause? It is going to cause a prominent canon. It's a prominent A wave, but in few conditions you can get canon A wave. But in our question, they have asked only prominent A wave. So if you have a prominent A wave, then your answer is going to be tricuspid stenosis. So what are the conditions where you can get a prominent A wave? See here, actually I told you this is the pulmonary artery. Pulmonary artery. So here, if you have a pulmonary artery obstruction, what is going to happen? The same thing can happen. If it is going to be a tricuspid stenosis, then again it is going to be the same thing going to happen. And sometimes what is going to happen is whenever a patient has a pulmonary hypertension, like this, the vessel is getting sclerosed, okay, because of pulmonary hypertension, what is going to happen? Again, the patient is going to have a regurgitation. Okay, so here we are left with three options here. One is RV hypertrophy, which is secondary to pulmonary stenosis. So these two can be clubbed together. Then pulmonary hypertension, again, it is similar to pulmonary stenosis. So again, you are going to club these three options together, and the leftover option is tricuspid stenosis. And tricuspid stenosis is the one which is going to have an MDM murmur. MDM murmur. So your answer is going to be here tricuspid stenosis. Tricuspid stenosis. Hope I am clear. Any doubt here? You don't. I hope you don't have a doubt here. It's a very easy question. Okay, very easy question. Okay. Then next question is, it's again a combination question where toxicology in medicine combined with forensic medicine and little bit of biochemistry is together. We have the next question. All of the following are features of cocaine toxicity except, okay, cocaine toxicity except. So what is this cocaine? What is this cocaine? So if you ask what is this cocaine is obtained from leaves of the plant called Erythroxylon coca. then extract from the plant. Okay, what this plant extract does? This plant extract will increase the norepinephrine, increases the epinephrine, and increases the serotonin surge. surge. So simply we can call it as there is going to be a sympathetic surge. Okay, sympathetic surge. Whenever there is a sympathetic surge, what is going to happen? The patient is going to have severe vasospasm. Severe vasospasm. Whenever there is a severe vasospasm, what is going to happen is the patient can develop myocardial injury. Myocardial injury. Okay. And whenever there is an increased catecholamine output, what is going to happen is the BMR is going to increase, basal metabolic rate is going to increase, and the patient can develop hyperthermia. And the second option is gone. Then the third thing is these patients can develop seizures. Seizures. Okay, seizures. Whenever there is a seizure, the patient is going to have altered behavior, or patient will be little agitated. Okay, so the patient might become agitated. The patient might become agitated. Okay, so here, as I told you, there is going to be a sympathetic surge, and this sympathetic surge, what it is going to cause? Is going to cause tachycardia and not bradycardia. So the answer here is going to be bradycardia. Bradycardia. So I have put up here. There are 3 stages in cocaine toxicity. The first stage, the patient is going to have CNS manifestation. Because of the vasospasm, the patient is going to have headache, vertigo, pseudo hallucination, and there is going to be hypertensive features, tachypnea, hyperthermia, and agitation. And later on, patient will develop encephalopathy and seizures. Okay, and the patient is going to develop arrhythmias, and this even is going to be a tachyarrhythmia. The last stage is stage 3, where patient will develop hypotension and failure features. So this is how a case of cocaine toxicity will progress, and here, based on this, our answer is going to be bradycardia. Bradycardia. Hope I am clear. Okay. Any doubt you have, you can let me know. But it's very simple question. I think so. Right. Next question. It's very good question. And last year's session, we have discussed this in and out in our endocrine class. I think so. So you would have done it correctly. I think so. Okay, for this question. Now we have a hypothyroid patient. A hypothyroid patient coming in altered behavior or altered sensorium in casualty emergency department. So whenever a patient comes to in an altered system, what we'll do a electrolyte screen. It's routine, right? So they have also done an electrolyte screen. And the report shows a urine osmolality of 1000 and plasma osmolality of 250. What is the reason? Now, whether it's a hypokalemia, hyponatremia, hyperkalemia, or hyponatremia, these are the options being given here. So always I tell water is living in relationship with salt in our body. So water and salt are always in living in relationship. Okay. So whenever you have water and salt, you have to calculate the osmolality. I'll show you the thing. Okay. This is the one. Okay. This is a normal person. He has water and he has salt. If the water is proportional to the salt, then the patient is going to have normal osmolality. Now, this patient has relatively more water. More water. When there is increased water, what is going to happen? Then relatively the salt is going to increase. This sodium is going to decrease. Okay. When the water and salt are equal concentration, then it is going to be normal osmolality. When water is greater than salt, then it's going to be decrease osmolality. Now the third patient is going to have very meager amount of water. So if you see that the water is very less here, water, and relatively the salt is increased. This is going to have increased. So these are three scenarios we are going to have in our patient. Okay, these are the three scenarios we are going to have in our patient. Okay. Now here, if they ask you, the patient is having, if you take this patient has plasma osmolality, decreased. Plasma osmolality decreased. So if you see here, the osmolality is decreased. Okay. So this means that the patient in blood has more water and decreased salt. And if you take here the urine, it is increased. It means that less water and more salt, right? So if a scenario is given like this, then what you're going to think that the patient has increased water retention, and because of that, relatively the salt has decreased, and this patient has developed a dilutional hyponatremia. So hope you have done clear in your exam. It is going to be hyponatremia as the answer, right? So hyponatremia is the answer here. So hope you're clear with this. Okay, any doubt here? I hope so. You will not have any doubt here. So we are done with this question, and this is a very, very easy question, and you would have done very well. Okay. And the next question, what I'm going to discuss, is going to be a very, very easy question. Okay. So years together they have asked this kind of questions, and a patient presents with diarrhea, dermatitis, dementia, and further probing, he having maize chronically. So he is eating maize for a longer time. Okay, and this patient is coming to you. Which vitamin is deficient? Okay, so you all know that whenever the patient presents with 3D, okay, few book says 4D because they include death also here. And if a patient comes with 3D, okay, then it is going to be niacin deficiency. Someone correctly told me now it is going to be pellagra. What is then? It is going to be B5 deficiency, and B5 is the answer. Yeah, this is very, very straightforward question, and hope the question would have been 100 out of 100. Okay, you people would have all done. Okay, so this is niacin deficiency pellagra. Okay, and the similar question was asked in the exam. I was not able to get the correct options here, but they have given a picture like this. Okay, picture like this. The same picture indicates the patient is having pellagra. Okay, and this patient has this dermatitis here. You can see the dermatitis here, and this is called as Casal's necklace. Casal's necklace. Okay, Casal's necklace. Okay, so again, this question you people would have done correctly. So no doubt in this. Okay, so we are coming to next question. Next question. A 35-year-old male patient, okay, male patient with a body weight of 70 kg and a serum sodium of 120. So patient is having hyponatremia. This is 70 kg fellow. The total body sodium deficit in this patient is going to be how much? That is the question. Okay. So this is again very, very, very good question. Okay, based on electrolyte. And this time we had a lot of questions in electrolytes kind of stuff. So whenever you have a patient with hyponatremia, you have to calculate sodium deficit, right? Sodium deficit. What is the sodium deficit? Okay, sodium deficit. Whenever you want to calculate sodium deficit, what you're going to do is you're going to multiply 0.6 into body weight, okay, by into desired sodium. Desired sodium is 140 minus, okay, this is 140 is going to be the total sodium required to reach. It should be the target value, okay, but over 24 hours, how much you're going to correct is going to be different from what is the target you're going to reach. That's going to be different. Okay, so now you have a patient with hyponatremia coming to you, 140 minus into body weight into 140 minus patient sodium. Okay. Now, this is 0.6 if it is a male patient. If it's a female patient, then you are going to use 0.5. 0.5. Okay, so now what you're going to do, you're going to use 0.6 into body weight is going to be 70 kg and 140 minus the patient is 20. Okay, 120. So it is going to be 0.6 into 70 into 20. Okay, so it will come somewhere around 840. Okay, so if you take simple thing, 7 into 240 it comes around 1400, and this is half of 1400, so 700 plus should be there, more than 700 should be there, right? So the answer is somewhere around 400. 700 is going to be this option, so I'm going to select this option as the answer. Okay, it's a very simple question. Okay, now always remember that whenever you are using a 3% saline, the saline is going to have 513 milliequivalents per liter of sodium. Okay, so per liter is going to have 530 milliequivalents. Okay, and it is per liter. Okay, so what 3% saline we have? We have 100 ml of 3% saline. Usually, what we have in what is going to be 100 ml. So it should contain 51.3 milliequivalent per liter. Per liter. Okay, so a single bottle contains 51.3 milliequivalent. Okay, 51.3 milliequivalent. So this formula is very important. Okay, very important. Okay, so you always should remember this. Okay, and always when you calculate the total deficit. For example, if you calculate this total deficit as 840, then 50% of this, okay, 50% of this should be given over first 8 hours, and the remaining 50% over next 16 hours. Okay, and the rate of correction should be less than 0.5 milliequivalents per liter per hour. So this you should always remember. You should keep it around 0.5 milliequivalents per liter per hour. That is the rate of correction to be maintained in the patient. Rate of correction to be maintained in the patient. Always remember this. Okay, so this is very important. Okay, always try to correct sodium at a rate of 0.5 milliequivalents per liter per hour. Okay, so if you are correcting it fast, okay, what is going to happen? What you are correcting? Yes, as you said, it is going to be a osmotic demyelination syndrome. The patient is going to develop ODS. To prevent ODS, slow correction is important. Okay, not more than 8 to 10 milliequivalents per liter per day. Okay, that is very important thing you have to remember. Very important thing you have to remember in your exam. Okay, so detailed discussions was done in the class, and we will do it further. If you're inter and if you're a final year, we will be doing discussions in our regular class regarding hyponatremia. But for time being, you remember like this. Okay, so this is about the sodium deficit corrections and all. I have given guidelines and all, so it will be very useful for you. Okay, then the next question is. So the 60-year-old female patient. Okay, this is how I got the stem of the question. So the stem of the question was an old female patient. She is a known case of diabetic, okay, and was admitted with persistent vomiting and history of food poisoning. Okay, she had vomiting and she had a food outside, it seems, I am assuming, and because of that, the patient had a food poisoning. Okay, so whenever with diabetes, okay, what is the complication or diabetic emergency you will think? You will think DKA, diabetic ketoacidosis. You will think about acidosis. So whenever you have a patient, okay, like acidosis, what you're going to think it is going to be an acidosis. Okay, so you will think it as acidosis, but wait for the twist and turn here. The patient has persistent vomiting. persistent vomiting. Now, imagine this person is going to be like this. This diabetic patient is going to look like this. Yes, this is going to be his stomach. Okay. Now, this patient is going to vomit out its contents. Vomiting is there. Vomiting is there. What is going to happen whenever the patient is vomiting? Okay. What is going to happen? All the acid are going to come out. Acid are going to come out. Whenever acid comes out, what is going to happen here? Increase in alkali. So there is going to be alkalosis. Alkalosis. So based on the history, I'm telling you. Now, whenever a patient comes like this, what is the next step you are going to do? The patient looking very sick. So what your PG is going to order? The PG is going to order for ABG. And one more thing, what is given here? The patient has hypertension because of volume loss. The patient has hypertension. Okay. Now, when you do a ABG, the first step in ABG is to look at the pH. Right? Look at the pH. So here the pH is going to be 7.52. Yes, 7.52. Okay. Whenever the pH is more than 7.4, then it is going to be alkalosis. Alkalosis. Next, what you're going to see? PSCO2. Second is PSCO2. When you see the PSCO2 here, it is going to be 20. It is decreased. Decreased. Okay. And next is the patient has a bicarbonate of 26. Okay. Actually, this patient is having alkalosis. Okay, alkalosis. You take this point as 24. Okay, 24 as the mean value, and it is above 24, so it is going to be a metabolic alkalosis. Okay, metabolic alkalosis. Then we have to check whether it is gone for a compensation or not, etc., etc. So it is delta plus 15, the formula. Now it's beyond the discussion of this session, and here the answer is going to be persistent vomiting. Why persistent vomiting? You can ask me. RTA acidosis, septic shock, lactic acidosis, DKA acidosis. The only option which is left over is alkalosis causing condition is going to be persistent vomiting. Persistent vomiting. So the answer is going to be persistent vomiting. So this is very, very easy question. If you apply your concept very well, whatever way you have listened in the class, whatever you have read, it is very, very, very easy question. Though this question is not to go about with the instinct gut feel. It's going to be a problem based question, and it's going to be a how you solve the question. Okay, so this is about this question. The next question is a female patient. Okay, the female patient. Okay, the word which is given is very, very important. It's a known case of microstenosis. Okay, so the patient is having a valvular heart disease, the native valve. Okay, so it's a valvular heart disease in a female patient who has an irregular pulse. Okay, irregular pulse means what's going to happen? The patient is going to have atrial fibrillation, right? Atrial fibrillation. So whenever you have atrial fibrillation, what you're going to do? You're going to do an echo. Okay, so echo, because why you want to do an echo is echo will show whether there is a thrombus or not. Okay, this thrombus can discharge and it can cause stroke. Okay, so whether the patient has thrombus or not, according to the question, the patient has no thrombus. Okay, which is very good, very good. The patient has no thrombus. Okay, now the patient is a valvular heart disease. The points I'm going to take as snippets or key game changers. Okay, valvular heart disease, it's going to be microstenosis and it's going to be a native valve disease. And the patient is going to be a female patient, very, very important. And the patient is in AF and echo was done, no thrombus. No thrombus. Okay, what is very, very important about these things is this patient, whether this patient will develop into stroke or not. If he is going to develop stroke, we have to go for prophylaxis. Okay, prophylaxis to prevent thrombus or embolic dislodgement. So what we are going to use is we are going to do a Chats-to-Vasco. This we have discussed in our neurology session also. Okay, Chats-Vasco. So if I take the Chats-Vasco here, this patient, our patient is a female patient. So the score is 1. Okay, and they have not mentioned anything about the age. They have not mentioned anything about the age. So here the patient Congestive heart failure history is not given, hypertension history is not given, age not given, diabetes not given, stroke not given, past history of stroke is not given, vascular disease is not given, okay, and again age is not given. Only thing is given this 6 category, which is the score of 1. So what this score says, if the score is 1, you have to prefer oral anticoagulant or aspirin. Okay, the score is 1, then you have to prefer oral anticoagulant or aspirin. I say that it is oral anticoagulant more than aspirin you will prefer. Okay, more than aspirin you will prefer. Now this is a chart I have taken from the guideline. Okay, it's based on the ACC, American College of Cardiology, and European Society of Cardiology guidelines. Okay, so the patient is coming to you with A. Okay, and you have to see whether it's a valvular AF, okay, or non-valvular. Valvular AF means it's a rheumatic cause of AF, valve disease causing AF, or it's a non-valvular or other causes of AF. So valvular AF, okay, directly you have to go to vitamin K antagonist. Vitamin K antagonist, right? Vitamin K antagonist. If it is not a valvular AF, then what you're going to do, you're going to go for our CHAD-VAS score. CHAD-VAS score. If the CHAD-VAS score is 0, then you have no role of antithrombotic therapy. If the score is 1 or 2, you will plan for oral anticoagulation. With this oral anticoagulation, if you are planning, you have to go for some score called a Has-Blood score. What is the problem with this Has-Blood score? What is the significance of this Has-Blood score is, this Has-Blood score, okay, Has-Blood score will tell you whether the patient has any high risk for bleeding because of the oral anticoagulants. For that reason, you have to check for the Has-Blood score, and then you will go for either a newer or novel oral anticoagulant or vitamin K antagonist. So I already told you vitamin K antagonist is going to be warfarin. Okay, it depends upon the situation. You will go for either a NOVAC or a vitamin K antagonist. But in our patient, okay, based on the clues being given here, it's a valvular heart disease, right? Female patient, right? Atrial fibrillation is there, and there is no thrombus, so you plan for an anticoagulation, and the option here is going to be warfarin is the correct option. Warfarin. Hope you have done this question very nicely. So this similar discussion we had in our class in neurology when we were discussing the stroke, right? A similar kind of question being asked here. Okay, similar kind of question being asked here. So again, this is one big chart. Okay, so native valve, that is the patient is not on any mechanical valve or bioprosthetic valve. If you have a mitral valve disease, okay, mitral valve disease, and if it is a rheumatic mitral valve disease, okay, then you go for vitamin K antagonist. Okay, this flow chart hits on the face and says that this is warfarin the answer. Warfarin the answer. This is table from Harrison, which says that Harrison says that warfarin is a vitamin K antagonist. Okay, and you have to outweigh the benefit and the risk of bleeding, and based on that, you're going to give for the patient warfarin. Okay, all these dabigatran, rivaroxaban, apixaban, and edoxaban, all these are newer oral anticoagulants, and the dabigatran is a thrombin inhibitor, direct thrombin inhibitor, and rivaroxaban, you see here rivaroxaban as a XA. So this is direct NA inhibitor. So hope I'm clear with this question. Okay, so I hopefully you would have done this question very nicely. So no problem. This question you would have faced. Okay, so this is about this CHAD-VAS score, and this is again from Harrison. Okay, so any patient, majority of the patient require chronic anticoagulation. Okay, but the selection of the agent is based upon the patient profile. Okay, so any patient with mitral stenosis, hypertrophic cardiomyopathy, or a prior history of stroke requires uh, requires anticoagulation. Okay, and patients without mitral stenosis are often referred to as having non-valvular AF. This I have told you, and you are going to use the CHAD-VAS score, which we have already discussed. Okay, and if the score is 1 or 2, 1 you have to outweigh the clinical benefits, and two, definitely you have to go for oral anticoagulants. Okay, oral anticoagulants. And even though even though they say these dabigatran, thrombin inhibitor, rivaroxaban, apixaban, edoxaban, all these drugs are superior, okay, in some way to warfarin, but warfarin is the agent required for patients with rheumatic mitral stenosis or mechanical heart valve. So here our ideology is to go with rheumatic mitral stenosis, and the answer is going to be warfarin. Okay, so you would have done this question correctly. So I have full faith on you. You would have done this question. Okay, so you have done this question correctly. Okay, so this is again a plumb question, which created some kind of confusion, or while I was discussing with few students. Okay, there was some alterations that they were telling that this should be the answer, this should be the answer. But we will discuss here and make it sure why this answer has been the best answer, and why the key should have this as the answer. Okay, so we are going to discuss the next question. A 25-year-old female software engineer presented with complaints of weakness, tiredness, fatiguity for 1 month. She was on continuous work 14 hours per day. Okay, eat packed junk foods, and her diet was deficient for fruits and green leafy vegetables. Okay, so ideally this case scenario more fits into COVID period. A female software engineer who is in work from home scenario, and what she's doing is she's always in front of the computer typing something, and what she was doing is she was taking in between food. Okay, junk foods. Okay, not containing any green leafy vegetables or fruits. Okay, this scenario more commonly fits the guy who prepares for entrance examination, PG aspirant. Okay, they also do similar thing. They'll be in front of the computer and they'll be eating something, which is packed food. Okay, so the options here are acute blood loss, folate deficiency, vitamin B12 deficiency, and hemolytic anemia due to toxicity. Okay, these are the options. So what will be your answer? Yes, I can hear you. Yeah, someone is telling it's vitamin B12 deficiency, but most of you would have selected this as vitamin B12 deficiency, but this is not the answer. Okay, the answer I prefer here, and even whatever references I got, is that it's going to be folate deficiency. Okay, we'll see why it is folate deficiency, right? Okay. So these are the causes of megaloblastic anemia. Okay, what are the causes of megaloblastic anemia? The first cause is going to be vitamin B12 deficiency, right? Yes, vitamin B12 deficiency. The second to be folate deficiency. Folate deficiency. So other causes are there, okay, which are independent of cobalamin and folate. Okay, we are not considerate about those options. We are source of food. If you see this food, is the folate containing foods are green leafy vegetables. Okay, green leafy vegetables. In our patient, there is no green leafy vegetables was taken, and because of that, the patient has developed a megaloblastic anemia. Megaloblastic anemia, and the correct option here to be selected is going to be folate deficiency. Okay, so I hope I have explained it. Okay, if it is vitamin B12, then it is veg diet patient. If it is a folate deficiency, then the patient is having NV diet. Here the V diet is here the NV diet is not there. Here the same diet is okay. So this is again a very good question. Okay, it's a thought-provoking question. You have to just think, okay, a few seconds to get the answer. Now, a CKD patient, okay, a CKD patient with GFR of 30, okay, GFR of 30, with edema and hypertension, which are the following drug you will advise for the patient? So this question asks, what is the drug you will prefer in a patient with CKD, and if this is the list of drugs being given, what is the drug you will prefer? Okay. So the first thing is, whenever you have a patient with CKD, based on the stage of the disease, the drugs will differ. If you want a patient to be on hypertensive treatment, the first drug is going to be AC inhibitor or ARBs we will prefer. ARBs we will prefer. But this is when contraindicated whenever you have an increasing creatinine. See your creatinine is increasing, then you are not going to give ACE inhibitors and ARBs. Okay. And few books says if the creat is more than 2.5, then also you will not give ACE ARBs. So here in our option, we don't have ACE ARBs, so the headache is over. Okay. Now coming to the option, propranolol. Why propranolol is not the option? Okay, not the correct option. Propranolol, it's a beta blocker. Okay. Beta blocker means failing heart. Okay. In the patient is having decreased cardiac output, and decreased cardiac output is going to have decreased blood flow in already failing kidney. Now, if you give a beta blocker, what is going to happen? It's further going to worsen the renal blood flow, and that is further worsening of the kidney. So it is ruled out. Prozosine is the alpha blocker. It is also not used here. Okay. Then aliskiren. What is aliskiren? It's a direct renin inhibitor that you can give, okay, give in states of hyperaldosteronism, okay, resistant hypertension and all you can give. But here, I don't think so. It's a wise choice to give a CKD patient aliskiren. Okay, here we are going to go for thiazide like diuretic, chlorthalidone. Okay, thiazide like diuretic, chlorthalidone. Okay, so chlorthalidone can be given. One very good drug we can give up to GFR of 10. Okay, less than 10 and dialysis patient is not effective, but you can give in patients with end-stage renal disease more than GFR more than 10, you can use this drug. Okay, so this is one good question where they have combined medicine, that is nephrology, with clinical pharmacology. And if instead of this option, there is another one option, is there, metallazone. Okay, if this is an option, then I will prefer this as the correct answer. But unfortunately, this was not given an answer. So I'm going to go for chlorthalidone. Okay, I'm going to go for chlorthalidone. This is how you will treat a patient. Okay, the first drug of choice is ACE or ARBs. Okay, ARBs. Okay, so this is how I'm going to treat a patient with hypertension and CKD. And the next question. A HIV positive patient, okay, presented with history of cough and sputum production and fever. On examination, findings were suggestive of consolidation in the right intrascapular area, and X-ray showed a right lower lobe consolidation. His CD4 count was 55. What is the most common cause of his illness requiring admission? Okay, so this is again a thought-provoking question. Okay, this was a well-framed question to make you get confused. Two options. Right. Okay. So here the problem or the clinical scenario given is HIV patient. Okay, and his CD4 count is 55. Okay. Whenever even when I took class in pneumonia, I was discussing about the characteristic organism causing lung involvement. Okay, it was PCP or Pneumocystis jirovecii. So on seeing those 2 points, what you will think is the answer is going to be Pneumocystis jirovecii, right? And yeah, you thought like that. But if you are good enough, if you are wise enough, if you are concentrating properly the question, you would have done correctly. Most of you would have done correctly, I think so. Okay, because you would have observed. We have discussed a lot of clinical questions, and we know how the twist will be given in the question. Okay, so all through the 1 year, we have discussed a lot of clinical questions. When we discussed our regular medicine class, we discussed a lot of clinical questions. I told you how to think about how to crack a question, right? So think about the question. Okay, so these points are distractors. What they have asked is the patient has a history of cough with the sputum production and fever. Okay, in our regular ADR class, what I have told you, if it is sputum production, okay, then it should be caused by a typical bacteria, a typical organism, it's a typical pneumonia. Okay, wait for it. Next is the patient is having consolidation in intrascapular area, and X-ray also confirmed right lower lobe consolidation. What is required more than this, friends? This is going to be real game changer, right? So here, the right lower lobe consolidation is present. I told you the difference between a typical pneumonia and an atypical pneumonia. And typical pneumonia will show a definite feature in X-ray. It can be a bronchopneumonia, it can be a lobar pneumonia, or it can be involving the whole lung sometimes. Okay, but if it is atypical pneumonia, it is going to be interstitial pattern, right? Interstitial pattern, and there will be paucity of symptoms and signs. Paucity of symptoms and signs. This we have discussed several times, several times. And in our regular class, we have discussed the most common cause of pneumonia is going to be Streptococcus pneumonia, right? Community acquired pneumonia, the most common cause is going to be Streptococcus pneumonia. The answer is Streptococcus pneumonia, right? Hope you have done it very nice, done very nicely, and you would have done correctly. Okay, so I have put two X-rays, okay, for you. Okay, so this is the first X-ray. Okay, this X-ray shows area of consolidation with the pleural thickening. Okay, and you can see sometimes here, you see closely watch here, there is something white here, and inside there is black. So this is pneumatocyl. Okay, pneumatocyl. And if this pneumatocyl is present, then it is going to be a case of staph pneumonia, which is the most common cause of hospital-acquired pneumonia. So here it is not exactly the same what is being given in the clinical scenario. Next, this X-ray. Okay, this X-ray. If I give this X-ray to you, what you will say? Sir, X-ray looks normal. Okay. Yes, X-ray looks normal. Okay. But this patient is having mycoplasma. So there is going to be an active infection in this patient, but there is going to be paucity of symptoms. Paucity of symptoms. But our patient has consolidation in the lung. Then we come to third X-ray. Third X-ray is like this. Okay. So you can see the lot of interstitial pattern here. Okay. Like typically it is going to be a tree pattern, but here you are going to have infiltration in the interstitium. And this is an X-ray of a patient who is having TCP. And the last X-ray is going to show lower lobe consolidation, which is similar to our patient. If it is a lower lobe consolidation, then it is going to be definitely a community acquired pneumonia the patient is going to have, and the most common cause is going to be strep pneumonia. Strep pneumonia, and I hope you would have done correctly. You would have marked the correct answer as strep pneumonia, right? Right? Okay. So don't get confused with this. This is most common pneumonia. Even if it is a HIV patient, the answer is going to be strep pneumonia. Okay. Next. This is from Harrison. Okay, Harrison. So why I have taken Harrison here is in few places I would have taken specific book, but Harrison is going to be the one which is going to be the main key in your exam. Okay, in your exam, whenever the examiner sets question, most of the time the question is from Harrison, and this is again from Harrison. Okay, so pulmonary disease is one of the most frequent complication of HIV disease. So pulmonary complications, most common HIV disease. The most common manifestation is going to be pneumonia. So HIV, more common is pulmonary disease. If pulmonary disease, more common is going to be pneumonia. Okay. So here the 10 most common age-defining illness are recurrent bacterial pneumonia. Recurrent bacterial pneumonia they are given, tuberculosis they have given, and pneumonia due to fungus they have given. Okay, pneumonia due to fungus. So we are having these three options. And what is the correct option? Bacterial pneumonia is seen with increased frequency in patients with HIV infection, and patients are HIV infection are prone to infection with encapsulated organism, Streptococcus pneumoniae. So your answer should be Streptococcus pneumoniae. So hope I am clear. The answer is going to be Streptococcus pneumoniae. So this is how you are going to crack your question. Okay, and this is how you would have cracked in your exam also. Okay, I hope you have done this question correctly, right? Okay, so with this, again, I will tell about TCP. TCP, the patient is going to have a non-productive or productive with only scanty white sputum. Okay, scanty sputum or very very weak sputum. Usually, patient will tell that it's there is sputum. The patient is going to tell you dry cough. Okay, dry cough. Okay, next question. A male industrial worker in benzene factory factory. Okay, I hope this will be a clincher. Benzene factory for 20 years he is working, and he is complaining of fatigue and frequent hospital visits due to infection, which are the most common occupational cancer the patient will be having. The options are lung, bladder, blood, and liver. Liver. Typo error, liver. Okay. So this is again one important area which is being asked frequently and repeatedly in TSM and in medicine also. Okay, medicine also. So here, benzene factory. Okay, this is a direct pickup from a table in Harrison. Okay, so always you would have confused with bladder and blood. Okay, so here the patient is exposed to benzene industry. Benzene industry means the patient is going to suffer from AML, acute myeloid leukemia, and the answer should be AML, that is blood cancer. If it is benzene, about it is going to be our acute myelocytic leukemia, which is going to be our blood cancer. Okay, so this is about the occupational. This list is very, very important. I will share the list with you people, and this list should be your bookmark in your whatever source of material you are studying. Okay, very, very important, very, very important. Okay, then the next question: a patient presented with the acute onset of vomiting, and she or he was prescribed an anti-emetic drug, and followed by patient developed abnormal position and movements. Okay, abnormal position and movements. So this testing is very seem to be little vague. You will not be able to identify what is the reason. Okay, so the patient was having onset of vomiting. Okay, acute onset of vomiting, and whenever there is a vomiting, the medical officer is going to give two drugs, domperidone and metoclopramide. Okay, this metoclopramide being a D2 blocker, okay, going to be a dopa blocker. So what is going to cause is it's going to cause EPS symptoms. The EPS symptoms which we discussed in our class, right? We discussed this time dystonia. So the patient is going to develop dystonia. Okay, dystonia. Okay. So whenever a patient has dystonia, what you are going to give? You are going to give benzithol. Benzithol. This is the correct answer. And again, this is again going to be a direct pick from Harrison. Okay. So what Harrison says, okay, the drugs which causes dopamine receptor blockage or which blocks the central dopaminergic transmission are going to cause movement disorders. Okay. The common drug for nausea or vomiting, what we give is prochlorperazine and metoclopramide. These two drugs are the culprit most commonly. Even I have seen a patient who was given MCP and he returned back with the abnormal position. He was looking like this. He was looking. I'm telling, look at me. He was looking there. This is dystonic posturing. Okay, dystonic posturing. Okay. So these patients, okay, what you will prefer? These patients, you have to give a drug, okay, a drug which is going to increase the dopamine, and it is going to be tetrabenazine. Okay, tetrabenazine. In that tetrabenazine, we have a drug called valbenazine. Valbenazine. Okay, valbenazine. So this is the drug. The class also we have discussed about butyrated tetrabenazine. Okay, in the class also we have discussed butyrated tetrabenazine. Okay, so you would have done this question correctly, I think so. Okay, butyrated tetrabenazine we have discussed in the class. Okay, if you go and take your neurology text, neurology notes, and if you see, we have discussed butyrated tetrabenazine. Okay, butyrated tetrabenazine. Okay, so you would have done this question also correct, right? Okay. The next question I want to discuss is, this is again a question which we discussed, a similar kind of question in our exam. I told you to calculate score also. I remember that. Okay. Now we have a 70-year-old male patient. Okay. So this is very, very important here. Male patient with fever, cough, and sputum. and had bronchial breath sounds. His respiratory rate was 20. Okay, he was okay. And urea was 44. Okay, that is blood urea nitrate rate was 44, and BUN was 44. Okay, BUN 44. Okay, and his BP was 110/70. So, what you think as diagnosis? Only when you don't know the diagnosis, we can go for the next plan of management. Okay, next plan of management we can go for. So, what do you think this diagnosis here? Huh? What is the diagnosis? Fever, cough, sputum production. So, you think about pneumonia, right? Pneumonia, right? Okay, you think pneumonia. Okay. So, whenever you have a pneumonia patient, what you're going to do is you're going to use a score called curve 65. Curve 65. Okay, curve 65. What is curve 65? Okay, you see here we have the curve 65. Confusion. This patient has no confusion. So 0. Blood urea nitrogen is 90. Okay, blood urea nitrogen is urea by 2. Okay, 2 urea by 2.4. We take it as 2. So our patient is going to have a urea 44. 44 by 2 is 22. Okay, so this is fulfilled. So we have a score of 1. Respiratory rate more than 30, but our patient is having 20. So this is not there. This is not there. BP 90/60, our patient is 110/70. So this is not there. Age more than 65, our patient is 70 years. So this is there. So this patient has a curve 65 of 2. A curve 65 of 2. What you are going to do when the curve 65 is more than 2? It is 2. If it is 0/1, then you have to treat OPD, give oral antibiotics and send the patient home. If it is 2, then you are going to admit the patient in ward. If it is more than 3, then you are going to admit the patient in ICU. And depending upon the patient condition, you need intubation, then go for intubation. So our patient is having a score of 2, and this patient has to be admitted definitively and treated in the ward. Okay, so based upon the patient profile, you'll go for antibiotics or not, that which kind of antibiotic you select. Everything depends upon the patient profile. But for time being, in casualty, you are going to classify the patient as having a curve 65 score of 2, and you're going to admit the patient. So here the answer is patient should be admitted in the ward. Okay, so this question you would have done correctly because we have discussed this question in our class. Okay, this similar question we have discussed in our class, so you should have done this question correctly. Okay, then next is which of the following statement is false in relation to pheochromocytoma? Okay, which of the following statement is false in relation to pheochromocytoma? The first option is treatment of choice is surgery. Diagnosed by urine DMA and catecholamines can present as episodic hypertension with vomiting. Propranolol is given the initial treatment for hypertension. Okay, initially it is given for treatment of hypertension. These are 4 options. Okay, what you're going to think? What is your answer? We have discussed this, right? This question we have discussed. So you should you should tell me now what you have said. First option, treatment of choice surgery. Yes or no? Yes. Okay. Diagnosed by urine, DMA, and catecholamine. Yes or no? Yes. Can present as episodic hypertension, vomiting? Yes. Hypertension is one of the feature. Resistant hypertension, rather, resistant hypertension is going to make you think that the patient is a young patient who is going to have pheochromocytoma. Yes. So propranolol is no. Okay. Even if you try to rule out the options, you will be able to rule out the options. Or if you want to specifically see propranolol, it's a beta blocker, right? So always I told you that it is A to B. Okay. So always in a patient with the pheochromocytoma, it is alpha blockade followed by beta blockade. Alpha blockade followed by a beta blockade. Why? When you give propranolol, alpha blockade will be there. Alpha will be there. Alpha and opposed action will be there. So alpha causes vasoconstriction, and there will be further worsening of the hypertension. For that reason, it's always alpha blockade followed by beta blockade. Okay, so we will see the thing. Okay, so patient is coming with the catechol secreting tumor. So pheochromocytoma, you are thinking. So hypertension is a clinical feature. Epigastric chest pain can be a clinical feature. Constipation can be clinical feature, and nausea vomiting can be clinical feature. Okay, these are the clinical features. Okay, now the next thing is how you're going to go with the diagnosis. Okay, so whenever you have a patient with clinical suspicion of Pneumonia, what you're going to do is, if there is a high probability, then you're going to go for 24-hour urine fractionated med, fractionated catecholamines. What is this fractionated med? Okay, we're going to check for metanephrine and normetanephrine. Metanephrine and normetanephrine. Okay, if it is catecholamine, then it is dopa, noradrenaline, adrenaline, or norepinephrine and epinephrine. Okay, so these are the things you're going to check, and plasma fractionated metanephrine you're going to check. Okay, if it is a low probability, then you're going to go for 24-hour urine fractionated metanephrine. So this is the step one. Okay, so in always in our endocrinology class, we discussed that we are going to go by steps. Okay, the second step is, if it is going to be a case of pheochromocytoma, as you suspected, then you next you're going to go for localization. The localization is done by adrenal or abdominal MRI CT, and you are going to get confirmed it. So this is the biochemical test. And the last one is functional confirmation. So you are going to do a 123 MIBG scan, okay, and the latest one is gallium dotted PET scan, okay, dotted PET scan, and you're going to give a alpha blockade followed by beta blockade, and then you're going to go for surgical resection. In surgery, at the time of surgery, when you touch the tumor, there is high chance of patient going into hypertension. Okay, for that reason, you're going to use NPG. Okay, NPG. The preparation of the patient very important in pheochromocytoma management. Okay? Preparation is very important in managing a pheochromocytoma. Okay. So this question you have done well, right? Yes. The next question is going to be the question where a 25-year-old, okay, male patient from Chhattisgarh is coming to you. Okay, Chhattisgarh is coming to you. So you will be wondering why Chhattisgarh is given. Okay, so sometimes they can give even Madhya Pradesh and Bihar, Orissa also they can give. Okay. Now, this patient presents with muscle weakness, spasm in leg, and gradual onset of pure motor cancer. A very important word is pure motor cancer. Very important word. Going to tell you the diagnosis. Okay, tell you the diagnosis. If it is the following options given, what you will ask for. Okay. The first is fever history. Why fever history? Okay. So here the patient is presenting with weakness and spasm in the leg and gradual onset of pure motor weakness. If you think it is a GBS, then it is fever history is important. So usually there will be a fever followed by the patient has over a period of 2 to 4 weeks, the patient can develop weakness which will start at the lower limb and then go over the upper limb. But here, so in GBS, the problem is that it is motor greater than sensory. Sometimes the patient will have tingling sensation and ascending paralysis is given. But here it is not given, so this option is below. The same thing holds true for GBS with vaccination. Okay, lot of cases have been COVID vaccine, even after Zika virus infection, even after rabies vaccination. Okay, the patients have developed GBS. So again, this is ruled out. Then past history of similar episodes. Okay, past history of similar episodes and muscle weakness, gradual weakness can be there in multiple sclerosis. But multiple sclerosis will not occur only with motor involvement, can involve other systems like patient can develop optic neuritis, patient can develop something like patient palsy, something like trigeminal neuralgia. Anything can be of that sort can be there. Okay. The last option is diet history. Okay. Diet history. This is very important. Okay. Why this is very important? Okay. So in those the people in this part of area are going to have their food as kesari dal. Kesari dal. Okay. What is kesari dal? The normal dal. Okay. In the sambar, dal, gravies, what you make, they use this dals. Okay, these dals are called as lacerous saliva. Okay, when it is contaminated, it contains a toxin called as BOA. Contains a toxin called BOA. What is BOA? Beta oxalate amino alanine. Aminoalanine. Yeah, aminoalanine. So this toxin is going to cause degeneration of the neurons. Okay, degeneration of the neurons, and it's going to cause upper motor neuron type of uh, involvement, or which is going to be pure motor involvement. Okay, so this is very dangerous, and the patient will be like this. Okay, I was fortunate to see one patient like this. Okay, fortunate or the guy is unfortunate. Okay, and this guy developed like this motor paralysis. Okay, motor paralysis which involves the lower extremities, and this is a classical picture of teaching. Okay, this is how a patient will be with neurolaterism will be there. There will be a bent forward posture. They will not be able to walk, and they will be using assisted movements, assisted devices to move around. Okay, so this is a case of classical case of neurolaterism. So what they mean here is it's going to be bad history because it's contaminated case result, and the patient developed pure motor paralysis. Okay, hope I am clear with this. The next question is going to be a pregnant female. The pregnant female who is a known case of hypertension is coming to you, and she is now pregnant and to uh, wanted to check the treatment what she is taking. Okay, or whether you want to change anything. That is what being asked. Okay, a pregnant female who is a known case of hypertension on treatment. If if any one of the following drugs can be changed, what you are going to change or what you are going to stop. Okay. So if the four options are labetalol, methyl-dopa, calcium channel blocker, and AC. These are the four options. Okay. So if you take a patient with hypertension, the drug of choice is going to be labetalol and methyl-dopa. These two drugs you will prefer. Okay. Uh, And if there is some contraindication, then you can go for calcium channel blockers. Okay, and calcium channel blockers should be discontinued just before the labor. Okay, then you can go for cardioselective beta blocker. Okay, with intrinsic sympathetic activity that is going to be atenolol, metoprolol, indolol, and butalol. Okay, if you are left with no other option, then you can go for cardioselective beta blocker. Okay, and prozosine and clonidine can be given if there is no uh, first dose hypertension effect and not, okay, post hypertension effect. Then you can go for this. So these are the drugs which are preferred in pregnancy. What are the drugs to be avoided in pregnancy? The drugs to be avoided in pregnancy are VC inhibitors and ARBs. Okay, because they are going to cause severe fetal malformations, okay, growth retardation. So you are going to avoid VC inhibitors and ARBs. Diuretics, okay, non-selective beta blockers to be avoided. Okay, the propranolol like drugs to be avoided, and sodium nitroprusside is contraindicated. So these are the drugs which are contraindicated in pregnancy, and our answer is going to be yes, guys, clear, right? We have done this question correct, I think so, right? So next question is going to be 55-year-old female patient presented with persistent headache, ESR was high. Okay. Last week also I saw a similar patient. Okay. So she is around some 50 years old patient, and persistent headache and ESR was high. Okay. Was diagnosed as GCA. So what I did is I ordered for a USG of temporal artery. Okay. And planned for a biopsy, and it turned to be a James cell apparatus because of granulomatous inflammation. Okay, the similar thing I'm seeing in this patient. Okay, I'm seeing in this patient. Okay, so this patient is having the same feature. What is the first line of treatment in this patient? Tocilizumab, prednisolone, NSAID surgery. What you're going to prefer? Okay, so this is from Harrison. Okay, so the goal is to reduce the symptoms. Okay, and prevent visual loss. If it is going to cause damage to the vision, then you're going to start, not going to wait for the reports and all, you're going to start treatment immediately. Okay, so the first drug of choice is going to be glucocorticoid therapy with prednisolone of 40 to 60 milligram per kg per day for 1 month. You have to go for prednisolone. Okay, prednisolone. Okay, so this is the definitive treatment. Okay, definitive treatment. And ESR is a useful indicator of disease activity. We have seen this. And coming to tocilizumab, more effective in genital arthritis and approved by FDA, but it does not form the first line of treatment. First line of treatment is going to be our urology. Okay, and if it is going to be life-threatening and eye-threatening complication, then you have to start aspirin. Don't wait for the report. Start an aspirin. It is going to be life-threatening and eye-threatening complication. So this question you have done would have done very nicely because we have discussed this question again in our regular class. Okay, I stressed upon the treatment initiation several times during the class, and this question has come in the exam also. Okay, so this pattern of question has come in the exam. So hope you have done clearly. Okay, so next question is going to be about a 60-year-old patient with history of CKD operated for pyolithotomy. Okay, is a known case of CKD and operated for pyolithotomy. So post-operatively, which drug you are going to prefer in for post-op anesthesia? Okay, post-op anesthesia. So the options are diclofenac, acetaminophen, indoxacarb, and naproxen. A, B, D are odd man out here. C is the different one here. C is going to be different one here. Okay. Before going into that, we will discuss why this drug which can be given or not in CKD or any patient with a renal problem is very important. Imagine this as a glomerulus. This glomerulus has a afferent arteriole. It has a different arteriole. So whenever you want to filter as glomerular filtrate, what should happen? Normally, this area should go for vasodilation. So whenever there is a vasodilation, what is going to happen? More amount of blood is going to get retained here and this is going to be filtered. And afferent artery should go for vasoconstriction. Okay, so that the blood is retained in the glomerulus for a longer duration. Okay, usually afferent vasodilation and efferent vasoconstriction is required. Now, our gentleman, our patient had requires vasodilation. What is required for vasodilation? Prostaglandin is required for vasodilation, right? And what is required for vasoconstriction? Okay, JC is required for vasoconstriction. That is what required. But now, if you give a prostaglandin inhibitor, okay, what is going to happen? There's going to be vasoconstriction. So what is going to happen? The patient's CKD will worsen. And if you give a AC inhibitor, what is going to happen? Efferent vasodilation, and patient is going to have decreased CFR. So this should not happen. Okay. So what is the drug which is going to inhibit the prostaglandin production? Yes, anyone can tell me? Tell me. Yes, you would have thought correctly in your exam because when I was discussing about scleroderma, I was discussing this point. I think so. So you should have done this correctly, right? This similar thing I was discussing when I was discussing scleroderma, right? So this is going to be NSAID. NSAID. Okay. So it's clear, right? NSAID. NSAID. Okay. So NSAID, if you give to the patient, is going to cause vasoconstriction and is going to cause worsening of the patient. So here, diclofenac is the NSAID, indomethacin is the NSAID, naproxen is the NSAID. If you not give the treatment here is preferred is going to be acetaminophen, which is going to be our paracetamol. Okay, paracetamol is the only drug which you can give in this patient as post-op analgesia. Okay, post-op analgesia. Okay, so this is the diagram which I was trying to explain you guys. Okay, so you would have done this also correctly, right? Okay, very good. Next question. In iron deficiency anemia, all are increased except, okay, in iron deficiency anemia, all are increased except, okay. So they have given TABC, transferrin saturation, transferrin receptor, RBC, protoporphyrin. Okay. Now, this question is very, very easy question. Okay. So this is an age-old question, very, very, very easy question. Okay. So anemia. Anemia means the hemoglobin is less, iron is less. Okay, very good. Okay. This iron will come and bind to normally to transferrin receptor. Normally binds to transferrin receptor. Okay, transferrin receptor. Now, our patient, what is going to happen is there will be decrease in iron. Okay, whenever there is a decrease in iron, now there is no one to bind to transferrin receptor. So what is going to happen to the transferrin receptor level? The transferrin receptor level is going to increase. Okay, increase. Whenever your iron binds to the transferrin receptor, it means that the transferrin receptor is saturated. Now there is no iron to bind to the transferrin receptor. What is going to happen to the transferrin saturation? Transferrin is going to decrease. Okay, going to decrease. Okay, whenever your hemoglobin is formed, it requires protoporphyrin binding to iron, iron to form hemoglobin. Now, what happens here in our patient? Iron is decreased, so protoporphyrin is 3, RBC protoporphyrin level is decreased. Okay, then the the iron binds to transferrin receptor. Okay, so when more iron binds to transferrin receptor, the total iron binding capacity will decrease. Okay, but here what happens? There is no iron, so transferrin receptors are free. So there is the binding capacity is free. So TABC will increase. TABC will increase. Okay, so if you take here, the answer is going to be all are increased except the transferrin saturation. So this is going to be the answer. Okay, if you are not convinced with this, we will go into the Harrison table. Okay, this is a very, very important table I have discussed several times. Okay, in test and discussions or in revision classes and all. Okay, so marrow iron stores will become zero in iron deficiency anemia. Serum ferritin, that is storage form, also will decrease. Okay, what will happen to the TABC? TABC will increase. What will happen to the serum iron? Serum iron will decrease. What will happen to the saturation? Saturation will be decreased. Okay, then RBC protoporphyrin level will increase. Okay, RBC protoporphyrin level will be increased. And the patient is going to have microcytic hypertension. So this is very, very important, and I hope you would have done this very nicely. Okay, the next question is 20-year-old boy with backache for more than 30 minutes. Okay, I can see the smile in your face. Okay, so when you saw this question, you would have had similar smile in the exam. Okay, so lasting for more than 3 months. Okay, and bilateral heel pain. Yes, you remember, right? So this question we have discussed, right? So okay, these eyes were red and painful. Okay, red painful. So the patient is having some kind of uveitis like teacher, right? Okay, so what is the answer? What is the answer? What is the answer? Yes, I wanted to confuse you, so I put twice final TP. The answer is ankylosing spondylitis. Okay, correct. You have done very nicely. Okay, very good. This we have discussed in our regular class. Okay, several times, and you remember the pictures and all. I think so. Okay, so now a patient with AS is coming to you. Okay, his age of onset will be less than 40 years. Okay, there will be an initial symptom of dull pain, insidious in onset, lower lumbar and gluteal region, accompanied by low back morning stiffness. So patient on getting up, okay, wake up, wake up stiff. As day progress, becomes free or loose. Okay, he is comfortable. Okay, so you can ask me, sir, patient had backache. Why can't it be a disc prolapse or a spinal TB or a mechanical pain? Yeah, it can be. But what are the things? Okay, here the patient has bilateral heel pain. Why is this bilateral heel pain is there? So if you remember the slides in the ankylosing spondylitis, there is something I was discussing, that enthesitis. Yes, yes, enthesitis. This enthesitis is the one which is present in this patient. So this enthesitis is absent in mechanical back pain and it is absent in this prolapse patient. spinal TB, if it should be the answer, then the patient should have fever, okay, and it should be a it should be of the age also can occur any age, less than 10 years. Also, it can occur more than 50 years also. So specifically, the patient is a young adolescent patient, then it means more towards ankylosing spondylitis. Okay, ankylosing spondylitis. And this is what I was discussing. There will be enthesitis. Okay, enthesitis. This is again from Harrison. Okay. So even our regular class in our ADrPlexus, we discussed, we used to tell that, okay, helping this. Okay. So this is from Harrison. And the X-ray will, from the recollection, I came to know that there was an X-ray given, and you can see here the bamboo spine appearance, and you can see the syndesmophytes, the other spine. That is okay. Okay, longitudinal ligament getting calcified, thickened, and it is dagger spine. Okay, so you have done this question correctly. Yes, 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 yes. Okay, the next question, guys. When you saw this question, you should have remembered me, right? Okay, I was stressing this point in the exam. I mean, in the class, I was telling that the similar question I gave you, right? Similar question I gave you in the class, right? So you should done this question correctly. Okay, so you guys should have done correctly. Okay, so this question, even I felt happy when I saw this question because the same data question we had discussed, right? So a patient presented with headache, okay, for 6 months. The patient was on analgesic regularly, but recently her headache worsened with the medication, and she felt relieved on stopping the medication. What is the diagnosis? So, the, again, tension headache ruled out. You know the reason. GCA ruled out. You know the reason. Migraine ruled out. You are knowing the reason. It is medication overuse headache or medication abuse headache. Okay. So, what is medication overuse headache? Guys, you should have done this correctly. Okay, it is called by different names: analgesic rebound headache, drug-induced headache. Lot of different names are there. Okay, when you use analgesic for more than 15 days a month, okay, for more than 3 months, okay, then this should be called as analgesic overuse or abuse headache. Okay, so this question you would have done correctly. Okay, and this question you done correctly, right? Yes. Okay. Hopefully, you would have done correct. Okay. The patient presented with clinic with bitemporal hemianopia. On imaging, it was found that arterial aneurysm impinging on optic chiasma. What is the most likely artery to be involved? Okay. So I told you in our class, the most common aneurysm, very aneurysm, especially. I told most common are ACOM meets anterior communicating artery. And the ACOM meets anterior communicating artery. That is the most common site of aneurysm. Okay, if I am overlapping this image into our optic chiasma, it will be like this. Okay, so this is the ACOM, and this is going to be a aneurysm here. This aneurysm from the ACOM will start impinging on the optic chiasma. So we all know that if I take the optic chiasma like this, so these are the crossing fibers of optic chiasma, and this is the fibers. Okay, this fibers is going to supply the temporal side. Okay, so these are the crossing fibers. These crossing fibers are going to supply the temporal side. And what is going to happen? The patient is going to develop bitemporal hemianopia. Bitemporal hemianopia. Okay, if it is going to be a bitemporal hemianopia, what is going to happen? The answer is going to be ACOM. Okay, bitemporal hemianopia, ACOM. It's usually a posterior indentation, which compresses the optic chiasma. That will be like this. Okay, and see here, this patient is having a ACOM aneurysm. This ACOM aneurysm here, you can see the multiple ACOM aneurysm, and this, if you do a perimeter, it is going to cause bitemporal hemianopia. Bitemporal hemianopia. So this question also you have done nicely, right? Nicely. Okay. Then the next question. Young female patient hyperventilating and she developed carpopedal spasm. What is the abnormality you will expect in this patient? This question also I have discussed. Similar question I have discussed in the class. Okay. So this is a patient. Okay. What she does, she hyperventilates. Hyperventilate. When she hyperventilates, what is going to happen? All the CO2 will go out. When CO2 washes out, what is going to happen? It is going to result in respiratory alkalosis. Okay, and patient is going to develop hypocalcemia. So in our class we discussed if it is albumin, the binding of hydrogen ions I have discussed, right? Binding of hydrogen ion I have discussed. Okay, so based on this, you can see that patient is having hypocalcemia, carpopedal spasm, hyperventilation. So the answer should be respiratory alkalosis. Okay, this also you would have done correctly, right? Okay, next question. This is again a good question. A good question. A patient presented to the emergency department with a retroexternal chest pain lasting for 3 to 5 minutes, subsiding with sublingual nitrates. Is a known case of metabolic syndrome on statins, beta blockers, and metformin. ECG shows LVH pattern with a flat T wave. Okay. So what is your diagnosis? So this question is a good question actually. Um, so what is happening here? The patient is coming with chest pain lasting for 3 to 5 minutes, relieved on sublingual nitrates, and ECG shows a flat T wave, no changes, not much changes. So we have two options here. One is unstable angina. The second option I have is going to be the second option I'm going to have is non-ST segment elevation. Okay, so I'm going to club these two things as a single component. It's the USA with STEMI. Okay, it can be USA or it can be STEMI. So if I take the guidelines, what guidelines say? Okay, what guidelines say? Okay, so the options here given is add nitrates, LMWH, increase the dose of beta blocker, add a DAPT with clopidogrel. DAPT means dual antiplatelet therapy with clopidogrel. These are the options being given. Okay, so what I will prefer. Okay, patient already on nitrate, but patient having recurrent chest pain. So what nitrate is going to have an additive effect? No. Okay, then increase the dose of beta blockers. Okay, beta blockers. So what by what you're going to gain by increasing the beta blockers? Nothing. So again, this is ruled out. Clopidogrel. Okay, again this is again controversy to say that SAPT single antiplatelet therapy is enough to say go DAPT, but even with the DAPT, whether the patient will have any improvement in his condition? No. So based on the protocol, if you see here, a patient with the NSME is coming to you. Okay, what you're going to prefer is you're going to prefer either unfractionated heparin or a low molecular weight heparin or a bivalentine. Okay, bivalentine. So these are the options. The first step is going to be this. Okay, so the first step is going to be anticoagulation with the heparin. It can be any form. It can be unfractionated heparin or it can be a low molecular weight. So we are left with best option as heparin. So it is going to be low molecular weight. Second step is assess for the bleeding risk. Okay, if the bleeding risk is low, then go for aspirin or prasugrel. They have told that go for prasugrel. The recent guidance has told that prasugrel, go for prasugrel. Okay, or aspirin with ticagrelor, or aspirin with clopidogrel. Okay, because aspirin with clopidogrel is advised in a late form of disease. Okay, so you are going to give 12 months of DAPT therapy, EAPT therapy. If the bleeding risk is high, then go for aspirin with clopidogrel. Okay, the bleeding risk is very high, then you go for aspirin with clopidogrel. Okay, and then you continue with one drug that is clopidogrel. Okay, then you are going to go for SAPT. We'll start with the DAPT and then SAPT. But you guys have to remember the first step. What is the first step here? It is unfractionated heparin, enoxaparin, or bivalentine. Okay, so this says clearly the answer is LMWH. Okay, LMWH. Right? Very good, guys. Okay, the next question. This again we have discussed in our class, a patient, numbness in the fingertip, face looks dry, skin tightened, ANA positive. Okay, so ANA is the initial investigation we are going to do, and the investigation shows positivity. And immunofluorescence showed nucleolar pattern. Nucleolar pattern. Guys, here I want to tell you the patient clinical feature is very important, and the investigation is very important. Okay, what this clinical feature tells us. This clinical feature tells numbness in the fingertip. First point is finger. Numbness in fingers stiff and the face looks tightened. The face skin looks tight. Okay, where you will get guys these kind of features. Okay, the features you get is finger getting numb. Okay, the finger might get numb in Raynaud's phenomenon, right? Raynaud's phenomenon. Very good, guys. Raynaud's phenomenon. The skin becomes tight in scleroderma. Scleroderma. Scleroderma, we have two types and all that we'll discuss. So Raynaud's phenomenon with the scleroderma, whether it is a limited one or a systemic one, it is going to be a limited one. So remember, we have discussed this in our class. This thing. So you recollect properly, it is limited one. Okay. Then investigation. The investigation shows ANA positive. So ANA is a common one for all many vasculitic disorders and many immunological conditions. So ANA positive. But what is giving us a clue is the immunofluorescence pattern. The immunofluorescence pattern shows a nucleolar pattern. Nucleolar pattern. Guys, you are able to recognize, right? The answer. Yes. Recognize the answer, right? Nucleolar pattern. Okay. So I'm going to take a table from Harrison. Okay. So a patient is coming to you with the skin involvement. Okay. And again, you can see there the patient is coming to you with ischemia of the digits, that is numbness of the digits. So it indicates Raynaud's phenomenon is present and it is seen in limited cutaneous vasculitis. Next, you go for a ANA positive. The ANA positive with ANA immunofluorescence pattern showing nucleolar pattern. Nucleolar pattern means the disease associated is going to be scleroderma. Okay, so knowing this, our answer is going to be systemic sclerosis. Guys, you would have done this question correct, right? So again, this question is very, very important, and you people would have done this question nicely, right? So the answer is going to be systemic sclerosis. So these are the questions I have got. I recollected the similar pattern of questions which were asked in the recent English exam, and hope you guys have done this exam very nicely, and you're going to definitely get the good number of best ranks. Okay, good number of best ranks. And if any questions if left undiscussed and if you feel it has been asked in exam, the similar pattern of questions or similar kind of topics can be shared with me. So we'll have a discussion on those topics. So this is just to make you aware how the questions are framed, how the questions can be solved, and how it is going to help the future generations, the sense the future people who are taking internship and the people in final years to crack exam. Okay, so this is going to give you a good idea how you have to plan your preparation. Okay, and definitely whatever we are discussing in class are going to help you in clearing your concepts, and it will also make you feel easy to revise your topics. Okay, so we actually teach you people, but you people are the real heroes who spend tireless nights in making the midnight oil burn to make the best out of your hard work. And I pray and I wish all of you should get your dream branch, and you should be successful as postgraduates in your dream branch. Okay, thank you all. Best wishes. See you all people when the results are out. And if any questions is left undiscussed, you can let me know. We will discuss those questions. Okay, thank you.